Robert Hasserjian. I'm a hematopathologist and I work at Mass General Hospital and Harvard Medical School. And my main interest in hematopathology is myelodysplastic syndromes and AML. I presented the ICC, or International Consensus Classification of AML, and Dr. Sanam Loghavi presented the WHO classification, as you know, an additional classification, and then Dr. Andrew Wei, a hematologist oncologist, presented his take on how to handle both classifications in practice. And I think the exciting thing that came out of this was that although there are some differences between the two classifications, they both are largely concordant in many aspects. For example, both now are establishing and increasingly recognizing defined AML genetic groups that have been validated by clustering analyses that look for specific disease classes. And I think it gives the clinicians a much richer understanding of the disease. It allows patients to be directed to more appropriate therapies that are risk adapted. I think the differences have to do with handling aspects like blast count thresholds, certain types of mutations that we don't fully understand. And I think where there are differences, it highlights areas that could be studied further so we can decide better how to treat the patients. And I think that came out in Dr. Wei's presentation, where he discussed aspects that he liked from both classifications and how using both in practice can, again, give us a more sort of three-dimensional view of the disease and understand areas where there are differences and need further study. Yeah, there were some questions. One was brought up about clinical trials and how the classifications would affect that. And I think one thing that was emphasized is that clinical trials should be written, and that was also something Dr. Loghavi commented on. Clinical trials should ask pathologists to make sure that the trials are written with language that allows patients to enter classified by either classification. I think that was part of the reason one of the entities introduced by the ICC is an overlap group of MDS AML, and the idea of that was to allow patients access to both MDS and AML therapies, and that's something that Dr. Wei mentioned was an advantage. And I think in order for that to be effective, I think the trial sponsors have to, and the pharmaceutical companies that develop trials need to kind of consider that group and, if appropriate, include those patients in their trial inclusion criteria. We're definitely in conversation. I think there will be another classification coming up. Of course, classifications are always evolving. And I think definitely we're all working, we all very much want there to be one classification moving forward. I think right now, in a sense, we do have two classifications now. They both have been released. And you know, at this point, they can't be merged in a sense. We do have the two. But in most aspects, they are concordant, and I think the idea is the next classification, which there's usually a new one about every 5 years, but we're already now 1 year after the release of these, so we're talking 3 to 4 years. I think we all are definitely going to work very hard to make sure it's one unified classification involving people from both sides to come together and learn from the differences and sort of have a harmonized classification that capitalizes on what we've learned from having two classifications over the past few years. One thing I can mention that I actually attended the AML MRD session, minimum measurable residual disease, and as a pathologist, that's something that I'm very interested in, is looking for measurable small amounts of disease. And I think it was exciting to see that in one of the talks that by intervening in patients who have MRD, and at least a subset, the patient's outcomes can be improved. And I think that's another area that does dovetail with the classification, because as we understand different genomic groups of AML and the patients get therapies, we need to understand how to measure the persistent disease in those. So I think one thing that I'm very excited about is better understanding how the disease responds to treatment, and better understanding how we as pathologists and diagnosticians can evaluate treated disease. So that was very encouraging to see that if we can pick up a small amount of disease, that can actually give the clinicians information. They can do something about it that improve patients' outcome.